Means you have a huge volume of patients who are not diagnosed at all. And half of those who are diagnosed are not treated. And half of those who are treated are not controlled. So this is the rule of half. And it is a very unfortunate situation in our country, but true. Now, why does this happen? Because there is a very light attitude to the whole thing from the doctor side, from the patient side. Look, this is a slide which tells you that first monotherapy and then addition, if it is not controlled, if the patient has been on metformin alone, the time taken to increase his dose to get his sugars under control is on an average 14.5 months. And if he's on a sulfonylurea, it takes about 1.5 years before you think of increasing. What happens here is when the patient first comes to the doctor, he says, you do diet and exercise and you take metformin and you come back after a month. He comes back and he says, oh, doctor, I have not done exercise, I have not done diet. Okay, he says, okay, and you come after another month and he disappears. He comes after 3 months because nothing really is happening to him. It's a very silent killer. And that is the unfortunate reality of this disease. This is a study done by my colleague Dr. Shashank Joshi. This is the START study, which looked at Indian patients, and what did they find? That almost 67% of the patients never reach their HbA1c target. And whether it is HbA1c or fasting glucose or postprandial, almost 66, 51, 62, 67% never achieve their HbA1c target. And that's again a very unfortunate situation. This is another study done by Uni Krishnan. This is the ICMR INDAP study. Treatment targets not met in a large number of patients. And if you look at treatment targets in diabetics, you have HbA1c, 52%, 57% have not achieved their target. The blood pressure, 46 have not achieved. LDL cholesterol, 51. And combined, if you look at all the three parameters, a whooping 85% of the patients are not at all controlled. This is a very unfortunate situation in our country. This is another study looking at how much time it takes for patients who are poorly controlled to intensify treatment and maybe even initiate insulin. And what they have shown here is this is patient on 1 OAD, 2 OAD, and 3 OADs. And the average time taken to really upgrade and control them is 6 to 7 years. We are wasting all that time. Very unfortunate. This is again the aggressive, this is what goes step by step. In fact, this slide is not being animated here. This will go step by step. His HbA1c always will remain around 8. If you do a very aggressive treatment, you can bring it down to below 7 and keep it there for a sufficient length of time. This is again from the UKPDS, which says that ultimately 70% of patients will require combination therapy to reach their targets. And so this is across the board, that you have very poor control right from the beginning. You waste time in controlling the patient. And if you look at UKPDS, it says that ultimately you need 70% will need a combination therapy. If you look at the number of medications taken, they usually increase with duration of diabetes, obviously so, because the diabetes progresses. You have IGT, you have a monotherapy, then you have a dual therapy, you have a triple therapy, insulin coming in and insulin-based regimes, and it goes on and on. There is no respite in any of these. And what we are doing today is we are treating to fail. We are just waiting to fail before we start increasing the dose of drugs. It should be the other way around. You should control them well and then try to knock off the medicines. That would be a more positive way of treating your patients. So, the approach of step by step, what is there in all the guidelines, is an approach called treatment to failure. When lifestyle modification and metformin therapy fails, We add on new drugs in our attempt to control hyperglycemia. Actually, what we are doing is we are reacting to that failure. We are waiting to see that we are failing, and then we are becoming active. What we need to do is become proactive right from day one. Control the sugars well, and then you will have a decent outcome for your patient. So, what are the potential advantages of early combination therapy? There is a rapid achievement of therapeutic goal. Now, here again, when you talk of rapid achievement of therapeutic goal, what is the rate limiting step in all this? It is hypoglycemia. And there are only two drugs which will cause hypoglycemia, a sulfonylurea and an insulin. If sulfonylurea and insulin are not on board, you are not at all worried about hypoglycemia and you can very comfortably and confidently achieve your therapeutic goal. Rest of the drugs, by and large, do not cause hypoglycemia. Obviously, you will need lower doses of individual agents when you're using in combination. You don't wait to go full dose with one drug, say metformin, go up to 2000 plus milligrams, and then say, oh my God, I have failed, and then add another drug, and then add another drug. No. When you use a combination right from day one, your dosage requirement becomes less, and the control is proper. And obviously, this combination gives us an opportunity to combine different oral anti-hyperglycemic agents which have complementary modes of action. All of them have a unique mode of action. Sulfonylurea is different, your glitazones are different, your metformin is different, your SGLT2 is different, DPP4 is different. So you have drugs which are acting at different sites in the pathophysiology of type 2 diabetes, and you can very nicely synergistically combine these two drugs or three drugs to get the desired effect without hypoglycemia. That is the crux of the matter. As of today, if you look at the therapeutic classes of agents available, we have 8 drugs, of which 6 are oral and 2 are injectable. We will not be discussing the injectables, the glucagon, GLP-1 analogs, and insulin. But in the orals, we have metformin, sulfonylurea, alpha glucosidase inhibitor, the glitazones, the DPP4 inhibitors, and the latest SGLT2 inhibitor. This is Ralph DiFranzo's beautiful ominous octet, which shows 8 different pathophysiological mechanisms by which blood glucose will increase. You have decreased insulin secretion, you have increased glucagon secretion from the alpha cell, which increases the blood sugar, you have increased hepatic glucose output, you have decreased uptake of glucose in the peripheral tissue, increased glucose reabsorption in the kidney, and most importantly, you have increased lipolysis, and there is lipotoxicity, which is going to kill your beta cells. So here you have a whole conglomerate of pathophysiological mechanisms by which you get hyperglycemia. And if you look at them, there is no way that one single drug is going to treat these different pathophysiological mechanisms. The UKPDA study is proof that as it has showed only a marginal relief and you need to go on adding agents. You need polypharmacy. In fact, 70% of patients in UKPDS needed combination therapy. So given this fact, why this is, actually this animation doesn't come. Now, given this fact, I think we need to be very aggressive in our treatment. Now, what do you mean by aggressive treatment? Yes, obviously you need a good glycemic control, but diabetes is not just glycemic control. You have diabetes, which is a dysmetabolic syndrome, where there is insulin resistance, obesity, hyperinsulinemia, associated hypertension. In fact, 50% of diabetics will have hypertension and more. As the years go by, it can go up to 70%. Dyslipidemia, classic dyslipidemia of diabetes is a high triglyceride, low HDL, and a small dense LDL particle which is highly atherogenic. And diabetes is a procoagulant state. So these are the things which we are going to really be treating to so that your patient has a long, nice, healthy life. And diabetics will have microvascular complications and macrovascular. By and large, the microvascular complications are driven by hyperglycemia. The macrovascular complications, which is a pro-atherogenic milieu, starts much before the onset of type 2 diabetes, and that the treatment is a very different ballgame altogether. Now let us look at metformin. Now we are going to be talking about the use of a combination of metformin and a DPP-4, that is linagliptin. Let us look at metformin individually. It is one of the oldest molecules. It is 50 plus years old. It has been in the market for many years. But in the US, it was approved only after 1995. But in India, we were using it much before that. We even had a fenformin, which is a brother of metformin, which because of lactic acidosis got banned. Metformin doesn't really cause lactic acidosis, though it has been blamed for it in many cases. Cochrane Review and others have clearly shown that the incidence of lactic acidosis is not increased with metformin. So, metformin is recommended by practically each and every guideline, whether it is ADA, ESD, RSSDI, you name the guideline. The first choice of drug is a lifestyle modification followed by metformin. And it has been known that the anti-hyperglycemic effect of metformin is mainly due to the inhibition of hepatic glucose output. So it's a very good drug to reduce hepatic glucose output. Whenever you have hyperglycemia, see, there are two main reasons why you have hyperglycemia. One is lack of insulin, due to which your cells cannot take up the glucose, and that is why the blood glucose goes on increasing. The other is an increased hepatic glucose output, which is driven by glucagon. So you have a situation where you have less insulin and more glucagon, and that is what leads to your hyperglycemia over a period of time. Now, the clinical use of metformin. Basically, metformin is a good drug, a very safe drug. The main side effects are GI side effects, which are nausea, vomiting, loose motion, flatulence. And these are all dose related. There are few patients who just can't tolerate a metformin. But a classic way of treating or using metformin is to start with a low dose and gradually over a week to 15 days build up the dose. The chances of side effects will be quite less. And metformin monotherapy can reduce HbA1c by almost 1.12%, which is quite good. And in fact, if you look at overall, higher the HbA1c, higher would be the reduction with the metformin, and it can go even up to 2. In fact, if you compare head to head, metformin is probably slightly more potent than even a DPP-4. This is from the UKPDS, metformin in overweight patients. This was the first study which showed the cardiovascular benefit of metformin in this subgroup of the UKPDS study in overweight patients, where they showed a 32% relative risk reduction in any diabetes endpoints, 42% reduction in diabetes related deaths, and all of them are statistically significant. 36% relative reduction in all cause mortality, and 39% reduction in myocardial infarction. This was the UKPDS in a subgroup of overweight patients. That is more important. This is another study which was published in 2019 by Han et al., where they looked at 40 studies, randomized controlled studies, and almost 1 lakh 10 lakh 66,000 patients with coronary artery disease. They looked at MACE, CV mortality, and all-cause mortality. MACE reduced by almost 17%, all-cause mortality reduced by 23%, and cardiovascular mortality reduced by 19%. This is what metformin can do. And this is a new study which is going on in the Netherlands, targeting aging with metformin, that is TAME study. Here they are giving metformin to patients 65 to 79 years old. And what are they trying to see? Whether giving metformin can delay the development of progression of age-related chronic diseases such as heart disease, cancer, and dementia. Because what they have found in animal studies is those animals given metformin for a sufficient length of time tend to live longer with less complications. So they want to see whether that could be true in humans. And that is a very interesting part of metformin. So, about metformin, there are multiple potential mechanisms by which metformin can benefit other than just reducing blood glucose. Blood glucose is reduced by reducing the hepatic glucose output. There could be an associated weight loss, though ideally speaking, metformin is a weight neutral drug. It is not a weight losing drug, but it can help in weight reduction. There is improvement in hemostatic function, reduced inflammation, oxidative stress, and inhibition of key steps in the process of atherosclerosis. Accordingly, metformin remains well placed as the primary drug of choice in treating type 2 diabetes. Now, let us look at DPP4 inhibitors. What is a DPP4 inhibitor? Basically, whenever we eat, from our intestine L cells, you have the incretin which is secreted. That is your GLP. So GLP-1 is secreted and it is immediately degraded by DPP4 enzyme. What DPP4 inhibitors do is it blocks that enzyme so that the GLP remains there for its action. And what is the effect of GLP-1? It stimulates the beta cells to secrete insulin, which is desirable in our patients. And that stimulation of insulin by DPP4 inhibitor is glucose dependent because it needs a sufficient amount of glucose to activate it. So if the blood glucose comes down, that insulin secretion also comes down. So that is why the chances of hypoglycemia with this drug are minimal if not present. So that is the beauty of this drug. The other action is you have an excess of glucagon, which causes increased hepatic glucose output and increases the blood sugar further. Even your postprandial sugars are increased highly because of that, not only fasting. So here, this drug will suppress the glucagon from the alpha cells. So it's a dual mechanism. It secretes insulin, which will bring down your blood glucose, and it will suppress glucagon, which will further bring down your blood glucose. That is the beauty of this drug. So hypoglycemia is not an issue. Weight gain is not an issue. It can be orally administered, unlike a GLP-1 analog. It improves the glucose tolerance and increases insulin secretion. It is weight neutral and very minimal risk of hypoglycemia, practically nil. Though I have seen patients going into hypoglycemia with DPP4, but that is a more of a theoretical thing rather than practical. Are there any disadvantages with DPP4? Yes. In fact, if you look at the US FDA, they have classified it as a drug which can precipitate heart failure, though it was only the Sabortimi study which showed that there was increased heart failure. The TCOS study with sitagliptin and linagliptin did not really show, but they have put it in one category as a. But now I think they're going to change that very soon. The other thing is that it can cause a little upper respiratory infections. Headache has been reported. Pancreatitis has been reported, though nowadays we find the incidence of pancreatitis because of DPP4 is practically not there. Arthralgia and arthritis has been reported, and that is a special US FDA warning that patients who are on DPP4 and develop polyarthropathy or arthritis should you should stop the drug and see. Generally, if it is because of that, in 1 month their arthritis will disappear. So this is what DPP4 inhibitor is all about. And how does DPP4 help? I have just discussed that with you earlier. There is no weight gain with DPP4. It is a weight neutral drug, which is very important. See, when you're treating a type 2 diabetic, what are you worried about? Hypoglycemia. You have only two drugs which will cause hypoglycemia, insulin and sulfonylurea. You're worried about weight gain. Which are the drugs which will cause weight gain? Three drugs: insulin, sulfonylurea, and pioglitazone. All the others are weight neutral. Weight negative are two drugs: GLP-1 analog and SGLT2 inhibitor. So here, this is a study which shows that compared to sulfonylurea, it is weight negative. Now, there are certain beneficial effects with DPP4 which have been seen, and especially with sitagliptin, linagliptin, they have shown these studies where they showed a reduction in urinary albumin creatinine ratio and a reduction in urinary albumin excretion. But we don't know whether this was an effect of blood pressure reduction or a good glycemic control. So, subsequent study was done where they used linagliptin, where they were all on stable doses of ACE or ARB. So BP was taken care of, sugars were controlled, and the effect of the drug was seen. And they show that at 12 weeks and at 24 weeks, there is a significant improvement from baseline in urinary albumin creatinine ratio, suggesting that these DPP4 inhibitors could have a positive role on renal function, preventing the progression and probably even reversing it to some extent. We have similar findings with SGLT2, but more robust than DPP4. So that is where we stand here. And this is another study, albuminuria lowering by linagliptin, independent of blood pressure reduction. And what is the reason? The renoprotective effect at the bottom you can read of linagliptin may be due to the inhibition of podocyte damage, inhibition of myofibroblast transformation, increased GLP receptor expression in the kidney. That could be the possible mechanism for the beneficial renal effects which are seen. This is efficacy of DPP4 inhibitors as an add-on to metformin. See across the board, if you see a DPP4 will reduce HbA1c by zero point 0.8 on an average. But when you add a metformin to it, it will be slightly more. And it all depends on what the baseline HbA1c is. If it is high, the reduction will be much more. If it is low, the reduction will be less. But that is where it is. So, what are the advantages of a fixed drug combination? So, here you have a fixed drug combination of a linagliptin with a metformin. What is the advantages? Convenience. There is ease of administration, ease of remembering कि मेरे को ये गोली लेना है. Efficacy, there is a synergistic effect between metformin and DPP4. Complementary mechanism of action. Tolerability and safety, less side effect because the dose is low. Economy, when you have a single pill combination, the cost definitely comes down compared to separate pills. So you have cost containment. एंड साइकोलॉजिकल पेशेंट फील्स बेटर कि मैं नंबर ऑफ गोली कम खा रहा हूँ. पेशेंट में अरे डॉक्टर साहब मैं 10 गोली खा रहा हूँ रोज. सो हियर द नंबर ऑफ गोलीज विल बिकम लेस. दैट्स द एडवांटेज ऑफ अ फिक्स्ड ड्रग कॉम्बिनेशन. And the potential advantage of early combination therapy. See, if you go early, once you are not worried about hypoglycemia, then you are quite comfortable. There, you can earlier achievement of therapeutic goal, potential reduction in the risk of side effects if you combine drugs with lower doses versus up titration of a single dose. See, if your patient is on, say, 1 gram of metformin, 500 twice a day, he is not controlled. You make it 500 thrice a day, and you make it 1 gram twice a day. The chances of GI upset, the chances of metformin induced side effects potentially increase much more there. So, here a lower dose and a better outcome. But and obviously you have potential to delay the progression because if you use a combination early on, the results are much better, the control is much superior, and you could have a long-term proper control. See, even psychologically speaking, when a patient comes to you with a high sugar and you treat him adequately, on his next visit he comes to you with a good sugar, he is happy with you that yes, he has come to somebody who can control my sugars fatafat. And that is what makes the big difference. Rather than you saying, अभी तुम lifestyle करो, कम खाओ, take metformin, मेरे को 1 महीने में दिखाओ, and the sugars are as high as they were. The patient loses the confidence in the doctor also. And the doctor also would feel miserable looking at the report. So you need to have very aggressive early combination therapy. Now, when you talk of metformin and DP4 combination, they are complementary mechanisms. If you look at the pancreatic beta cell, it enhances glucose dependent insulin secretion. Like I said earlier, glucose dependent. So if your glucose is high, you will have a good insulin secretion. If your blood glucose is low, the insulin secretion is blunted. That is done by DPP4. It suppresses glucagon secretion. Glucagon is what increases the blood glucose by hepatic glucose output. And there, that again is done by DPP4 inhibitor. Lowers hepatic glucose production. That is the mechanism for metformin, and the glucagon part also helps here. So DPP4 and these are complementary. Improves insulin resistance. That is done by metformin marginally, but there is no role of DPP4 in insulin resistance. Low risk of hypoglycemia. No additional weight gain. This I told you earlier. There are only two drugs which will cause hypoglycemia and three which will cause weight gain. So this is the complementary action of these two drugs. So what is the rationale for the use of this combination? Metformin with DPP4 inhibitors have obviously a complementary mechanism. Metformin reduces hepatic glucose output and improves sensitivity in the liver and muscle. And DPP4 inhibitor increases the GLP-1 levels, stimulates insulin secretion, inhibition of glucagon. It is a perfect made for each other combination. This is the same thing being expressed diagrammatically. I won't waste my time on that. Now, initial combination of linagliptin with metformin, there have been some studies done. There's a 24-week study on 791 patients randomized to one of six treatment regimes. What they did was first linagliptin 2.5 milligram plus metformin 500 BID twice a day. Linagliptin 2.5 plus 1000 milligrams twice a day. Then you had only metformin twice a day, 1000, and metformin 500 twice a day, and only linagliptin 5 mg once a day, as and compared to a placebo. And what did they find? Linagliptin 5 milligram once a day is 0.06, metformin 500 BD 0.8, metformin 1000 BD 1.2, Linap 2.5 plus metformin 500 is 1.3, 2.5 BD with 1000 BD is 1.7. And if you look at a non-randomized trial, it can go up to even 3.7. So both combination regimes are superior to respective monotherapy. And this is obvious. You don't need to be Albert Einstein to realize this. But this is a study which has proven that. These are some papers, initial combination with linagliptin, good for control. Here again, another early combination with linagliptin. The chances of achieving a tight glycemic control, HbA1c below 6.5 without increasing the risk of hypoglycemia or other adverse events is very much possible with this combination. So basically, to summarize, the goal of hyperglycemia management in type 2 diabetes is obviously to reduce HbA1c to minimize the risk of complications. So good glycemic control will minimize the microvascular complications. In the same, avoid weight gain and hypoglycemia. So this combination will not cause weight gain, will not cause hypoglycemia. DPP4 inhibitors have complementary mechanism of action, and combining these two early can provide an improved glycemic control along with obviously low risk of hypoglycemia and weight gain. By addressing the core pathophysiological mechanism of type 2 diabetes, the addition of a DPP4 inhibitor to metformin delivers comprehensive therapeutic advantage. DPP4 inhibitor and metformin have complementary mechanism of action that target three core defects of type 2 diabetes. One is insulin deficiency. Second, insulin sensitization. Insulin resistance at the liver is taken care of. Hepatic glucose output is reduced and glucagon is suppressed. So the three core defects are addressed by this combination, and that can significantly reduce both the fasting and postprandial glucose. Thank you very much, ladies and gentlemen. And I think I will take the questions, whatever they are. I can see one question here. Sir, what will be your drug of choice for a newly diagnosed uncontrolled diabetic? DPP-4 inhibitor or SGLT2? See, it depends. This is by Dr. Swapnil. Yeah, I can't read the surname, it's blocked. Dr. Swapnil. See, basically, when you talk of a newly diagnosed type 2 diabetic, you have to look at the age, you have to look whether there are any comorbidities, and then decide on the line of treatment. If he is young with no comorbidities, then an ideal drug would be a metformin in an Indian setting along with pioglitazone, and then you could choose between a DPP-4 and a SGLT2. Here again, I would personally prefer an SGLT2 or DPP-4 because it has got added benefits of weight reduction, and when PIO is on board, there can be a weight gain. The SGLT2 will neutralize that. But if his sugars are not very high, if he is not obese, and if he has any other comorbidities, then you will have to reconsider. And in our Indian setting, the commonest thing that I have seen where I cannot use a SGLT2 is a person having a balanitis or a lady having a vaginitis. And this is not uncommon, especially in a newly diagnosed diabetic. So that becomes a contraindication to the use of SGLT2. So that is where your metformin, DPP-4, and others would come in. I think there are other questions also, but yeah, let me see. All right, this is my good friend Dr. Salim Sachani who has asked this question. Sir, what would be the DPP-4 inhibitor choice for patients with uncontrolled type 2 diabetes with NAFLD? See, basically, non alcoholic fatty liver disease is becoming an epidemic. And fatty liver is part and parcel of insulin resistance. Insulin resistance is what is the driving force for non alcoholic fatty liver disease because when there is insulin resistance, there is a lot of free fatty acid release, and that is what accumulates in the liver, causing non alcoholic fatty liver disease, which can go to cirrhosis, which can go to hepatocellular CA also. The drug of choice here is a pioglitazone in patients with NAFLD. If he is a non-diabetic, then the drug of choice is a vitamin E. And there have been studies which have shown that vitamin E can help and pioglitazone can help. But let me tell you, any mechanism by which he can reduce his insulin resistance will benefit NAFLD, like regular exercise, weight reduction, SGLT2, DPP-4, GLP-1, which will all help in weight reduction, will be beneficial. So lifestyle modification will play a very important role, plus drugs. Among the drugs, the drug is obviously pioglitazone for NAFLD. Okay, I don't see any other questions there.
Yes, sir, there are no further questions. So can we wait for a couple of minutes?
Sure. I don't think there are any questions. Thank you.
So with your permission, shall we conclude this session?
Yes, yes, yes. Thank you very much,
Okay.
ladies and gentlemen, for having the patience to listen to me. Thank you.
Okay, sir. So on behalf of organizer, I would like to thank you for your insightful and educated talk. Thank you, sir.